Namaste everyone, a very warm welcome to another episode of Ask the Expert, an initiative by Vydehi Hospital where we bring leading experts in the field of health closer to you to answer all your health related questions. Today we'll be discussing about the intricacies associated with common cancers, especially women's cancer in general. Please join me in welcoming Dr. M.S. Ganesh, Head of Vydehi Cancer Center, Professor and Head Department of Surgical Oncology at Vydehi Institute of Medical Sciences and Research Center. Dr. M.S. Ganesh is a proud alumnus of Adiyar Cancer Institute, Chennai, with over 30 years of experience in performing cancer surgeries. He specialized in robotic surgery and performing complex surgeries like lipec and cytoreductive surgeries. Sir, it's a privilege to have you with us today. Thank you for joining us on the show.
Thank you. My pleasure.
Thank you, sir. The word cancer creates fear among all of us. Most of us completely avoid talking about it. Yet, it is important to learn the truths or the facts about this word so that we can overcome all our fears with hope. A lot of cancer awareness programs, a lot of cancer videos are circulating online, but we don't know what is true and what is false. Hence, it is important to learn from an expert about this condition. So, let us find out from our leading surgical oncologist. Sir, we hear a lot about cancer cases being on rise in our country. Is it really true?
It's true that the cancer cases are going up year by year. We see around 15 lakh new cases every year. And it is expected by another 10 years that number is likely to go up to around 30 lakhs. So the thing is, we do see more cancers. And the more important thing which I would like to tell is that not only new cases, patients who are living with cancers add up to this number. For example, at any given time in India, we have around 30 lakh active cancer patients at various stages. So cancers are on the rise if you see the numbers, and also because of some reasons which I would like to highlight to the public. One is the longevity goes up. Cancers go up in incidence and number. The average life expectancy in India has gone up in past few decades. So the number of old people are more. The more older population a country has, the number of cancer cases do go up. And we are changing our lifestyle into more westernized style. It comes with its own risk factors which pushes up the number. So certain cancers have definitely gone up, especially in women like breast cancers, pushing up the overall number. But I would also like to highlight that the fear is extraordinarily more than what everybody thinks. Yes. Still, cancers are important, but not to be feared so much that it is in some grave epidemic proportion. So I would like to say that.
Sir, if the cancer cases are really on the rise, there must be some reason behind that. Would you like to describe them?
Yes, I think I was talking about it when we talked about the increase. Most important is cancers are diseases of the old age still. So the moment we have more older population, the number of cancers are likely to go up. That is one important reason. Second is our habits. More and more we are trying to have a diet which is more westernized, more sedentary lifestyle, and tobacco consumption, alcohol consumption. These are all social perils you can call, which is really pushing up the cancer numbers. To some reasons, this is the main thing. And another important thing is that more people now come for testing. More people are aware that these are likely to be cancers, say they go and approach cancer centers or any hospital. So we see more numbers. So that way, cancers are going up because of these reasons.
Sir, also the general public is of the opinion that cancers affect only the older individual. Is it true?
It is true. Cancer is a disease of older population, but there is always a trend. What is in the past need not be now. In the past, it used to usually happen only in the old age. Even if we take our country, there is a slight shift in the trend towards the younger population. Still, the maximum age in India is above 45 years to 60 years, and actual incidence is high between 60 to 70. But in India, proportionately, if you see the population who are between say 40 and 50 are around 40 are slightly going up. So the younger population are seeing more cancers, not to an alarming proportion, but definitely there is a shift or trend like that. So young people can get cancers if they are not immune.
Okay. So we also know that breast cancer is the most common cancer in women in India. But why is it a major cancer in women?
Because breast cancer has become the most common cancer due to one very simple reason, as per me. Three things is everything cornering around the endocrine function of the women, which is affected by a combination of factors. Wherever I go, I put this lot of emphasis that breast cancers have gone up in Indian women because of the way their life has changed. It's more now less children, long age before they get married, and they are exposed to more female hormones. And the most important thing is what is called as a metabolic syndrome. I highlight this everywhere that more people really struggle with obesity in women, and that adds to a syndrome of metabolic consequences like PCOD, and then BMI being high, and then infertility, and all these leading to a combination of hormonal changes which are pushing up breast cancers in women. So as per me, that is one important reason why more and more Indian women are facing this thing. They have less children now, breastfeed less, and their dietary habits, sedentary habits, and more BMI struggle now in women. All these have pushed the trend even in rural women towards increased breast cancer incidence.
Sir, also we attribute a lot of diseases or even cancers calling it hereditary. So is breast cancer always hereditary?
There is a hereditary component in breast cancers. Around, you can say, out of every 100 breast cancers Indian oncologists see, approximately 10 to 15 are having a familial reason. It means it runs in families. Why it becomes important is many women are still not aware that if you have a strong family history, you are more prone than others. So they don't recognize this factor, but it's not alarmingly high. Out of every 100 women with breast cancers, 15 are likely to be due to hereditary factors. Remaining all are sporadic. I would still highlight that we are inviting that sort of disease.
Okay, sir, I think we are having a caller. So let's just talk to them. Hello.
Good morning, doctor. My name is Lakshmi.
Hello, good morning. Hello, Lakshmi, can you hear us? Okay, I think the call got
Call.
disconnected, so we'll see if we can connect with her again. Yes, doctor, we were. Oh, I think this is. Hello.
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 Good morning, doctor. Myself Lakshmi. I'm 51 years old.
Yeah, good morning, Lakshmi. Please, yeah.
Yeah, I had my mammography 2 years ago.
Okay.
So, how frequently should women could get mammography done?
Yeah. So we have Dr. Ganesh with us here today. He'll be answering your question.
Okay.
So, mammography has a definite indication when to do it. It
Okay.
depends. I again highlight, do you have a risk factor behind you, especially a family history? If you have a strong family history and you know at what age the family members got affected with cancer, probably 10 years less than that, the mammography starts and
Okay.
then goes every year once till nearly 65 to 70 years of age. Okay. If there are no risk factors, every woman crossing 30 should be self-checking once. Apart from that, the actual mammogram starts at 40 years of age and probably once a year till an age of around 70. I would say that.
Okay. Yeah, okay.
Thank
Thank you.
you.
Yeah, thank you. So, doctor, continuing with our discussion. Suppose if a woman presents with lump in her breast, what are the signs and symptoms that raise cancer suspicion?
Um, Again, by statistics, if we see 80% of breast lumps are benign. So 20% only are malignant. So if a woman has a lump, it depends on which age it is presenting. So above 40, the risk does go up. But overall, if you see, 8 out of 10 breast lumps are benign. But coming to the question, which are those lumps which are really likely to be malignant is any breast lump happening in a woman who's more than 40 years of age with a strong family history. The lump is, they are not painful as commonly people think. Pain is a later symptom. And it is hard, it is not moving, and it is growing continuously in size. Once these sort of picture is there, we do have a higher suspicion. But I have a very practical suggestion to most women. If there is a breast lump, do not take upon yourself to determine whether it is benign or malignant. Best thing is to consult. Show yourself up. It's a simple examination by a specialist to rule out that there is nothing wrong happening.
Okay. So now the woman has a lump in her breast. So what is the way forward? Because the general public are confused about a lot of tests which are available right now.
Again, there is a very simple algorithmic workup every oncologist or a breast specialist does whenever there is a lump. The important thing is to clinically examine by somebody who knows how these breast lumps present. So, clinical examination does give a clue whether one is dealing with a benign condition or a malignant. That's very, very important. So, go to an appropriate person who is capable of doing it. Second thing is to ask for a simple scan. So these scans range from a very simple ultrasound of the breast to a X-ray of the breast called as mammogram, and sometimes to a very advanced investigation like a contrast enhanced MRI. To brief younger the women, they better do with ultrasound or a contrast MRI. The older women can still do better with mammogram. Usually it's a combination of these tests. So this will show us whether we are dealing with a malignant lump, or it is suspicious, or it is benign. Once we have this idea, the next logical step would be to biopsy such conditions if there is a suspicion of malignancy. So a scan guided biopsy is the third step. That will tell us whether we are dealing with malignancy or not.
Okay. And also, doctor, around this biopsy, there are a lot of myths. It can cause cancer to spread and etc. like that. So, what are the truths and myths about biopsy?
As you said, it is a myth.
Yeah.
If biopsy is going to spread a cancer, I think anybody who undergoes biopsy by now should have been succumbing to the cancer.
True.
It is absolute myth. And secondly, without a biopsy, there is no way to prove whether a condition is benign or malignant. So it's 0% sort of truth that biopsies cause any harm. Except every time when a biopsy is done, doctors take precaution that patients are not on any blood thinners, and they are adequately covered for these procedures. Apart from that, there are no complications. It doesn't spread cancers, no.
Okay. Also, doctor, we often hear about the scan called PET scan or PET CT scan. So, what is it, and is it required in everybody?
It is a overdone scan, definitely. Everybody assumes that a PET scan is likely to prove whether a condition is malignant or benign. That's not a correct approach at all, because PET scan actually has its own pitfalls, and it can throw unnecessary findings which are going to confuse patient as well as doctor. So PET scan is never a routine test at all in breast cancers. Once there is a malignancy and the type of cancer looks more than early stages, then there is some benefit in doing a PET scan. Otherwise, no. The same holds good for many cancers. PET is never done routinely in all the cancers. So my take, it should be done with discretion.
Okay. Also, doctor, suppose now we have a woman who is diagnosed with breast cancer. How personalized or standardized her treatment should be? Or in other words, what do you mean by this personalized medicine or standard treatment for her?
Uh, Personalization in cancer treatment is a very large term. It's taught in various ways. Let us take, for example, breast cancer only. What would be personalized treatment for a breast cancer patient? First thing I would say is whether she is young or old. Second thing, in which stage she is presenting. Third thing, what type of breast cancer she has got. We have got 3 or 4 types of breast cancer. Each type has got a different type of approach towards medicines, towards surgery, and towards other treatments. What type? Fourth, when we are giving medicines, what are we choosing for the women? Okay, which way we are giving. For example, somebody who's a, let us say, IT worker, who's actively working, okay, and who's going to get a long treatment. I'm taking only an example. She would definitely benefit from chemotherapy delivered through an implantable device called a chemoport. It will spare her hands. It's much convenient. She can take. It's a small example. And more important, personalization is what are called as targeted treatments. Based on what markers the tumor shows, each patient is getting a specific type of medicine. Some are given, some are avoided, and at certain stages, some treatments are required, some are not required. Like this, a blanket approach is now avoided in most cancers, especially in cancers like breast. It takes time to figure out which patient requires which treatment. So we tell all women, be patient. You be patient because everything is personalized. There is no one blanket approach to every woman. So this is personalized medicine.
Okay. All right. So, doctor, also we hear a lot about something called as this multidisciplinary tumor boards. What is it?
Uh, Let us think like this. Many patients still are not aware what exactly the cancers require. They think surgery is enough, or they think radiation is enough. People do not know about radiation, and they do not know what a chemotherapy is and what are newer therapies like immunotherapy or targeted therapies are. So in cancers we have a group of treatments, and it is very what do you call wholesome to say in India most patients require a combination. It's very rare that a patient in India would get only one treatment. So when more than one treatment is required, the timing of each treatment is very, very critical in cancer patients. We cannot, for example, operate first when medicine should be given first and surgery should be done later. Okay. So who's going to decide these sort of things? If you go to one doctor, there could be a bias. There could be a misfounded belief that this treatment is right. So most oncology centers like Vydehi Cancer Center, and I'm sure many tertiary care cancer centers have this thing called multidisciplinary tumor board. At our place, it is for every patient. Like every patient goes through multidisciplinary tumor board at Vydehi Cancer Center. It means on day one, when you are fully investigated and you have all the reports, one person doesn't make a decision what treatment the patient should get. Surgeon is there, the medical oncologist is there, the radiation oncologist is there. So here bias is taken out and a proper treatment as per national or international guidelines are framed. They are documented even for future reference. So this is called as multidisciplinary approach to cancers, and it has been proven to be one of the very important aspects which has really led to improved outcomes in cancer patients.
Okay, doctor. Doctor, one of our viewers has commented, she has a query. So she says, can wearing bras cause breast cancer?
No. In simple terms, I would say no. It's another myth. No.
Okay. Also, doctor, this brings to our next question. So, what are the methods which are available to prevent a cancer, for example, cervical cancer?
Okay. So let's look like this. Probably 20 years back, cervical cancer was the commonest cancer in Indian women because 80% of population still resides in rural or town localities, urban population consists of 10 to 15% to 20%. Cervical cancer, which was the commonest cancer, is a preventable cancer. It is a preventable cancer because it goes through what is called as normal to precancerous to cancerous stage. It's got multi stages in it, and we know what is happening. And 80 to 90% of Indian cervical cancers are caused due to a virus called human papilloma virus. Okay, so we know the reason for cervical cancers in most Indian women. We know that it starts from normal stage and it goes through precancerous stage and comes through frank cancer. So cervical cancer is a preventable cancer by two methods. Either we vaccinate, which is the most correct way to do, which we can discuss in our talk in future. Cervical cancer vaccination is a very important way of preventing cervical cancer. And also, after vaccination, with or without vaccination, every woman who's sexually active should undergo a periodic test called as pap smears. They do smear the cervix and send them for cell changes or the viral markers on them. So these are going to tell us whether the cervix is healthy, unhealthy, what precautions should be taken for such things not to progress into cancer. So this can easily be prevented. Cervical cancer is a very, very good example of a cancer in Indian women which can really be prevented.
Okay. But doctor, a lot of people are apprehensive on taking this cervical cancer vaccination. So what's your comment on this?
It's like any other intervention in medical field where initially there are hiccups. Cervical cancer vaccination came with its hiccups worldwide, with some side effects, some serious issues happening. It's like any situation. You can take that call,
Doctor,
then
I
we'll
think,
discuss.
yeah, we'll continue the discussion. Hello? Hello?
Hello,
Yes, sir.
am I audible?
Yes, you're audible. Your name,
Yes.
sir?
My name is Mahesh, ma'am.
Okay. Please, sir, you can ask the question.
Yes. Hi, doctor.
Hi.
Hi, doctor. My name is Mahesh. I'm like 45 years old. I'm from Mysore.
Okay.
So, doctor, I have been smoking for nearly 10 to 15 years.
Yeah.
So, even if I quit now, my cancer risk reduce?
I would like to know how many years you have been smoking.
Like 10 to 15 years, doctor.
10 to 15 years smoking. I would put it this way. Today you terminate smoking, definitely the risk is going to come down. Okay. So compared to the actual risk which you will have if you keep smoking, if you discontinue it, not only cancers, all other related conditions like cardiovascular are definitely going to come down. But depending on how much you smoked, whether the risk is going to become zero in future, no. There would be some element of risk more than a normal population, which makes you a person to be screened for certain types of cancers. So I would say risk will come down, but it doesn't become zero.
Zero. Okay. But if I start, it will get.
That's very obvious.
Yes.
If we start, I think the risk will go up.
Okay.
Thank you.
Okay.
Thank you.
Thank you, Mahesh. Okay, doctor, so we'll come back to our discussion. So there's a
Correct.
lot of apprehension on cervical cancer vaccination.
Yes,
So,
coming back to our discussion, the cervical cancer vaccination was really criticized by many, even educated people, even doctors were very apprehensive to give it to their own children. They were not doing it. But all those things are now sort of unfounded, sorted out. So, cervical cancer vaccination is a pretty safe and established way of method which is now in vogue worldwide. Even in India now, many young girls and then married women do take cervical cancer vaccination. Because it's an important thing, I would like to highlight that at age it should be started is something which people are
true,
really
true.
confused. It starts as early as say 9 years as per recommendation, but the ideal would be somewhere around 12 for us. In India, what we do is say probably around the moment they reach around puberty age 12, we do recommend that take vaccine. Uh, from somewhere between 9 to 14 years of age, two doses are enough. It's now what is called as an vaccine with 9 valence. It can be given 2 doses, or somebody can also opt for 3 doses, but at least 2 doses to be taken, one now and one at the time, around 6 to 12 months. Okay. But somebody crosses into adulthood, say 18 years, more than 15 years of age, or they are really adults. Okay. The ideal thing is to give 3 doses of this cervical cancer vaccination. One now, one at second month, and third at sixth month. The protection is really enormous, and most women really have a long lifetime protection against cervical cancer prevention. So I think women should very actively consider taking cervical cancer vaccine in their family.
Okay, so it is recommended for both the men and women, doctor?
It is because cervical, the human papilloma virus also has a tendency to be causing issues with men also. Okay, it is recommended but women it is a very standard guideline.
Okay.
Yes.
Okay. So, doctor, now we know that early detection means the cure rates are also going to be high. Can all cancers be detected early?
No, no. So that brings us to very important question that why cancers happen. Okay, still 80% of uh, cancers which are associated with known things, we know what to do, when to detect, how to screen and do things. Okay, but there are many cancers where we are not very sure of the etiological factors. We don't know why they happen. Okay, so such cancers cannot be screened. There are no methods to screen such cancers. That is one. Second thing, when we have cancers which are not amenable for screening, for example, they are not very common. They don't provide tests which are really very, very useful to screen. It is impossible to look for cancers in everything. And third thing, when it happens is very important. It doesn't happen at every age.
Okay.
Take that question.
Doctor, I think we just. Hello.
Good morning, doctor.
Good morning.
Good morning.
I am Priya, 29 years old.
Yes, Priya. Please ask your question.
Yeah, I am breastfeeding my baby. Can breastfeeding reduce the risk of my breast cancer?
Yes. In one simple answer, yes. People who breastfeed are less likely to develop breast cancers, but it is not in a very major way that the moment somebody is breastfeeding, the risk is becoming zero compared. Absolutely no. If people have multiple, say, pregnancies and children, they are breastfeeding cumulatively for 1 year or more. For example, one baby 6 months, another baby another 6 months breastfed, or 4 months, 3 months, 8 months, like this. If we cumulatively breastfeed for more than say 12 months or more, the risk reduction would be somewhere around 4 to 5% reduction in the breast cancers. So there is some benefit in breastfeeding because when you are breastfeeding, the hormones are at their low, their action on the breast is negligible. So it's a protection. But is it a great protection that one can become complacent? No. But it does provide benefit, madam.
Okay. Thank you.
Thank you, doctor.
Thank you.
Okay. So we'll come back to
coming back to our discussion on does every cancer be screened? Not possible. There are only some cancers which are screened. For example, in women, definitely we screen for breast, we screen for cervical cancers, and we also screen. A lot of women also use tobacco, so we do screen them for head and neck cancers, oral cancers especially. Like for example, ovary is a very upcoming cancer in women. It's the third most common cancer now. It was not that common, but again, something like Similar to breast cancer, it has become common, but it is not easy to screen a ovarian cancer because its tests are not very fallible. I mean, sort of, they are fallible. They are not very standardized way of checking for screening, and it is some internal organ. So it's difficult to screen for a ovarian cancer with confidence. In men, again, if you see the lung cancers, like we had a question, if I stop smoking, will my risk reduce? It does reduce, but they are supposed to screen. But most men who have been smokers, who have given up smoking, actually don't go for lung cancer screening. They assume they have given up smoking, so there is no risk now. No, anybody who has a significant smoking history based on the pack years, it is called, they have to go for a regular screening of their chest and oral cavities for common cancers. And I would like to highlight here that smoking causes a varieties of cancers, both in men and women, tobacco. So it depends on what type of thing we are looking at. So not every cancer is detectable, every cancer is screenable. All common cancers where screening methods exist have to be screened. In the same context, I would also say there are warning signs. There are common warning signs called as 7 or 8 common warning signs every general public needs to be aware of. Okay, once these signs appear at any age, one should be careful.
Yeah.
So they have to go and they have to get themselves consulted with a qualified doctor to make sure that it is not a malignant conditions. Many people don't come on time. That is the issue. They don't know that it could be a cancer.
So, doctor, our audience would like to know about newer technologies like robotic surgery, which you perform, and advanced radiotherapy units. Can these lead to better outcomes?
It's a tough question. Every technology has a benefit. Technology benefits are twofold. One, it improves directly the cure rates of, say, for example, if you are talking about cancer, it could lead to better cancer outcomes directly or indirectly by reducing complications. Survival or good outcomes in any cancer treatment are twofold. One, direct reduction of cancers. Second is a reduction in side effects. So technology works in both ways. I can give example, take a robotic surgery which we do as an example and say, if you want to completely remove a cancer located at a complex area, like a prostate cancer or a rectal cancer very deep down in abdomen, all other approaches may struggle to get that, but a robotic would offer you a better vision, better approach in providing better outcomes directly to the cancer, especially in prostate cancer. It has been proven to be convenient. And second thing, it also prevents complications, which can lead to bad outcomes in patients. So directly, it can make cancer treatments better, robotic surgeries, if we take as an example, or it can reduce the complications, side effects, thereby improving outcomes. So, a patient's survival is dependent on two factors, both cancer related and treatment related. Definitely, robotic in its appropriate usage addresses both, the second one much more. That is for robotic surgeries. If you take radiation, radiation units are essentially they kill the cancer cells. Okay, all the advances in radiation therapy are delivery methods, how they are delivered efficiently by reducing side effects. Previously, due to the fear of side effects, the dose was reduced, the fields were reduced so that the tumors used to be undertreated. Advanced radiation machines now take both into cognizance. So it's a combination of these two technologies like robotics or advanced radiotherapy units lead to better outcomes. So I would say like that. Same with medicines. The chemotherapeutic agents, the targeted treatments are much safer. You can give them more specifically, decreasing side effects to the patient.
Okay, doctor, so we have one of our viewers who has commented that many people say that sugar feeds cancer and that stopping sugar can cure cancer. Is this true, and what does medical research say about sugar and cancer?
Uh, There is no direct evidence to say that you stop sugars, the cancers will reduce. There is no direct, it's not a direct carcinogen as we call. Sugar is not a cancer causing agent like a tobacco. But in my opinion, it has got some indirect ways of causing more problems. I would say problems. Again, I would like to highlight to all the audience about metabolic syndromes versus cancer. The cancers are going up due to various reasons through which we simply feed more now. We eat more, especially carbohydrates, less proteins, more carbohydrates, which are nothing but sugars. So these are likely to really push, and sugar is a pro-inflammatory agent, means it causes more inflammation. It's known to cause more inflammation. So inflammatory effect, increased obesity due to higher sugar intakes, all these are indirect ways where cancer instances can go up. So definitely reduction of sugar, and more importantly, generally taking cognizance of what we are eating and how much we are eating is a important way of looking at it. But if you say, is it a direct cancer causing thing? I would not say that right now.
Okay, doctor. Doctor, also many women in their 30s and 40s are being diagnosed with cancer, and most of them are working women. And how do oncology centers like Vydehi Cancer Center make it easy and tolerable for them and to get the best treatment and also to maintain that work balance?
Very important question, because I think more women are in work now. That could be really at a very top level, like a CEO or top administrative works, very important technical works, and to a simple clerical work, to even daily wage work. Most people are working because nowadays people are not at home, very less people. Okay, so whenever we feel we see these situations, treatments have to be tailored. We come back to the personalized treatments, not based on medical, what medicines you are giving them, but how you are giving them. For example, younger women who are working would like to continue work. So most, for example, breast surgeries are now daycare surgeries. Previously, they all used to come 2 days before, get all tests in the hospital, get operated, stay till all sutures are removed, 7, 8 days to 10 days, and then get discharged. Now, I don't think any woman is in a position to afford to stay in a hospital for 10 to 12 days unless it is really indicated. So, one thing, the stay reduction in hospital, especially for simple surgeries, are very, very common now. Most breast cancer surgeries are daycare surgeries. Come in the morning, go in the evening. Okay. Second, if you look at the chemotherapeutic process, as I emphasized previously, they do get implantable ports if they can afford. We do look at cost. We don't blindly say everybody get a chemo port. For example, there is a daily wage worker. We don't force implantable port on her. It will cost her some other treatments. So we are careful in telling what is important to a patient. But if they are affordable, every patient gets a port, which is an implanted device. Their hands are free to work. Most of them continue working. The chemotherapy is delivered through a port which is just under the collarbone, concealed, not seen, which is very, very convenient. Okay, so daycare surgeries, how you give chemo, all radiations are daycare. They don't have to be admitted. Even chemotherapies now are one-day affairs. Okay, in this situation, not only Vydehi Cancer Center, I am sure many cancer centers follow a method where women are looked at from their own job way. We don't want them to be giving up work and then trying to take treatments. It's loss of work. So these are some methods how cancer centers figure out how to address working women and young women. And in the same vein, I would say, let us take an example of a young breast cancer patient versus a older breast cancer patient. Okay, most young women would like to retain their breasts for surgeries. They are very, very apprehensive for cosmetic and social reasons that they would not like to lose whole breast to a surgery. So there is a very active consideration in a younger woman to save her breast So most of the women, wherever possible, undergo treatments to make it small first. But whereas if we look at the older women, the proportionate older women are okay to have their breast removed, but the trend now even in older women is to save it, because either saving breast or removing breast is not going to unduly affect outcomes. Okay, but younger women, always the emphasis is more. At Vaidehi, we also do robotic breast surgeries commonly. Getting technology and then young women is something which I say very small scars concealed around the nipple area. You can address lumps as well as the axillary area through robotics. And there is only one scar hidden around the nipple areola. Cosmetically, it is very, very comforting for them. It's a new area, but definitely it is possible. We have done significant numbers at our place. But again, we offer for patients who are eligible and who can afford. We don't push it because there is a technology at our disposal.
Okay, doctor. So you mean to say that there is a very convenient and a very feasible environment for all the working women to take treatment here if they are diagnosed with cancer. But also, how is the management or the infrastructure, and what are the provisions that the management gives or Vydehi Cancer Center provides to all the cancer patients?
So, from a age perspective and working perspective, we are looking at a very, very important aspect of cancer management. Okay, that is cost. The cost of, I think you should take that
Yeah,
question. We'll
okay.
discuss.
We'll discuss. Hello? Hello?
Hello.
Yes, sir. Can you hear us?
Yeah, ma'am, I can hear, ma'am.
Yes, sir. Please ask your question.
Ma'am, my name is Akash. I'm an IT professional. My age is 35 years, ma'am. I want to ask, sir,
Mm-hmm.
that we are commonly hearing about HPV vaccination. Is it for males also, and at the age of 35, can I take it, ma'am? Or if I'm not ignoring it, do males develop cancer because of this? And this is what I want to know, ma'am, regarding HPV and male vaccination.
Yeah, yes. So I would answer like this: HPV vaccination is not a standard of care in men, like in women, and one should realize what are the types of cancers which are more commonly associated with HPV in men. So the common cancer which is there is what is called as a oropharyngeal cancer, which happens at the back of the mouth, the areas like tonsils, back of the tongue, the palate, etc. So those are commonly associated with HPV in our country. So to your question, I would not agree that it's a routine indication to take HPV vaccination in men. No.
Okay, and that's the age of 35 years, I can ignore it, isn't it, sir?
No, it's not about age. They are associated with particular practices. Okay. So if you have a safe conduct of social and health related caring which you do, I don't think there's any indication at any age to routinely opt. At this age, definitely no.
Sure, sir. Thank you so much, sir.
Thank you. Thanks.
Thank you. Okay, so coming back to the infrastructure and the provisions by the management of.
So I would put it first this way, that cost is a major issue for patients, cancer patients. Okay, I have been in cancer management for last 30 or 35 years. Most of the defaults happen for only one reason: money. Okay, ours is not a insurance driven country. Most 80% of the patients are paying out of pocket. It's called as out of pocket expenditure, OPE. Most of them have to spend out of their savings. Okay, so the cancer treatments are pretty expensive because treatments are long, and as I said, most come not in early stages but in locally advanced or advanced stages. So they require more than one treatment, combination of treatments. So in that situation, cost becomes a very important factor. Okay. So one way how things become better is your multidisciplinary tumor board. It would clearly tell, do this, don't do this first, do this later. So patients have time to figure out what to do next. And if we take our place, we have a very active way of working out on finances first. That's a very important consideration we take. Okay, hospital is not like it doesn't work on a corporate model of enterprise where the growth drives treatments. It is not like that. Okay, money is essential for a survival of hospital, but it's not a enterprise. I would call like that. It's not a shareholder's perspective as we call. So it's important to see that many teaching hospitals, especially Vydehi Cancer Center and all, they do address the cost factor in a very different way. So they are very subsidized, first part. Like many pediatric cancer treatments are highly subsidized. Apart from that, we actively take all the governmental schemes. Actively, every scheme which is proposed by government is agreed upon and then followed. And third thing is we have a plethora of supports, which I am sure many are not aware. Many are not aware that the government of India at state level and at national level very actively supports treatments and then care. Really, we should be thankful to the government for that. And public are not aware. The hospital pushes it actively, these things. And then at every given point, if somebody is not able to complete their treatment solely due to money, Vydehi Cancer Center offers them reductions. It does take care of those helps. And we are tied up with a lot of crowdfunding agencies. Okay, so a combination of these definitely help patients. Management is very active in making sure that cancer treatments are subsidized.
Okay, thank you so much, doctor. We'll take a short break and we'll see you in a while.
Years of healing hearts, saving lives, and serving communities. And now, as we celebrate this milestone, Vydehi Hospital because quality healthcare should be accessible to everyone, not just a few. Introducing high-quality surgical care at remarkably affordable costs. Surgeries priced to match government scheme tariffs with eligibility extended to all patients. From general surgery and orthopedics to ENT, oncology, neurosurgery, urology, and more, all under one roof. Supported by experienced surgeons, modern operation theaters, faster recovery, and complete post-operative care. Trusted, reliable, affordable, delivering excellence with every patient we serve. At Vydehi, care is not a privilege, it's for everyone. Vydehi Hospital, celebrating 25 years of excellence and a lifetime of care. Of healing hearts, saving lives, and serving communities. And now, as we celebrate this milestone, Vydehi Hospital, Whitefield, Bengaluru brings you something truly special. Because quality healthcare should be accessible to everyone, not just a few. Introducing high-quality surgical care at remarkably affordable costs. Surgeries priced to match government scheme tariffs with eligibility extended to all patients. From general surgery and orthopedics to ENT, oncology, neurosurgery, urology, and more, all under one roof. Supported by experienced surgeons, modern operation theaters, faster recovery, and complete post-operative care. Trusted, reliable, affordable, delivering excellence with every patient we serve. At Vydehi, care is not a privilege, it's for everyone. Vydehi Hospital, celebrating 25 years of excellence and a lifetime of care.
Welcome back, everyone. Let us continue our discussion. So, many feel that cancers have poorer outcomes. So, what is your comment regarding to common cancers?
Wrong belief, because outcome is based on stage and the treatments available. So if you look at the outcome trends in India, survival has gone up for many cancers. Means people live now longer with treatments and more patients are cured compared to in the past. So it's a that blanket statement that all cancers carry poor outcome is not true. And it depends on which type of cancer we are dealing, number one. Second thing, at what stage we are dealing. For example, let us take again breast cancer as an example. Stage 1 and stage 2 are called as early breast cancers. 3 is locally advanced and 4 is advanced. Okay. There is a distinct survival difference between these three categories. Early breast cancers, the cure chances range between 80 to 90%. Whereas in locally advanced, it comes down to around 60 to 70. In stage 4, once upon a time, nothing was there. But still now, we have a percentage of people who survive and the cures are more. So it's not true that all cancers carry outcomes, poor outcomes. So I would not agree with it. Survival trends, as they are called, have shown improvements continuously over a period of time. Most cancers have shown better outcomes for two reasons. Treatments are more efficient, treatments are more safe, affordability of treatments, governmental and institutional support has gone up to treatments. So it's very, very important to understand that what we do and how we do does lead to better outcomes. I would also have a word of warning here. There are claims that completely they can be cured, we can win war against cancers and all. They are overstatements. They are not true. It's a journey where we have seen incremental benefits in survival outcomes. We are on that path, but it's a long way to go before we claim that we have substantially reduced mortalities in cancer.
Okay, sir. Doctor, we have one of our viewers by name Ananta asking a question. Which is more likely to increase the risk of cancer, active smoking or long term exposure to passive smoke? What factors influence that risk?
There is no doubt that active smoking definitely increases the risk. Definitely increases the risk. Okay. So it's directly related to cancers. Okay. While passive smoking also is associated with increased risk, it doesn't take down the risk. It does increase the risk, but not to the tune of a active smoking. Okay. Passive smokers are more at risk than people who are totally unexposed to tobacco smoke, either active or passive. But passive smokers are slightly at a lesser risk than active smokers, definitely. So it's graded. Active tobacco smokers are at very high risk. Passive smokers are at risk. Non-smokers are at really less risk.
Okay, doctor. Doctor, also, is there any universal test to detect cancer, or should we continuously keep screening ourselves for cancer?
Uh, Good question. Can we really start screening right through our life for cancers? Impractical.
True.
Impractical. We cannot do such things. But here I would highlight some things before we say, is there a universal test? Okay. Much has now come to what is called as counseling for tests, counseling for cancers. Okay. Who should test and at what age they should test and what tests they should undergo. So, like for example, every cancer has got a app-based approach or a risk-based approach tools which tell whether you are at a higher risk or lower risk or intermediate risk, and at what age one should start checking themselves up. Vydehi Cancer Center also has a women app specifically where all women-related common cancers are a survey-based, risk-based strategy where they are told at what age you should start yourself checking up. Okay, there are some cancers. I'll take few examples which could be very one could remember them, like colon cancer, which is based on a polyp-based condition called familial adenomatous polyposis, which happened to a gene called APC gene abnormality. If there is a family history and if people test positive for it, their chances of developing cancer is 100% by fourth decade. Means 100% they will develop colon cancers by the age of 40 or around that age. Okay. So for them, it is entirely a very, very sort of programmed, careful way of addressing what to do, how much to do, what to remove, when to remove, all those things. Okay.
Okay, doctor, we'll just take this. Hello.
Hello.
Yes.
Namaste.
Yeah, your name, please.
Madam, namaste.
Yeah, namaste.
ಮಾನಸ ಅಂತ.
ಹೇಳಿ ಮಾನಸ ಅವರೇ.
ಮ್ಯಾಮ್ ಇದೊಂದು ಲಾಸ್ಟ್ ಇಯರ್ ನಮ್ಮ ಅಂಕಲ್ ರಮೇಶ್ ಅಂತ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗಿತ್ತು.
ಓಕೆ.
ಫರ್ದರ್ ಈಗಲೂ ಕೂಡ ನಾವು ಫಾಲೋಅಪ್ಸ್ ರೆಗ್ಯುಲರ್ ಚೆಕಪ್ಸ್ ಮಾಡಬಹುದಾ? ಬೇರೆ ಥರ ಬಂದಿರುತ್ತಾ?
ಸೊ ಇದು ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಯಾವಾಗ ಮುಗಿಸಿದ್ದೆ ಅವ್ರಿಗೂ?
ಲಾಸ್ಟ್ ಇಯರ್ ಆಗಿತ್ತು.
ಏನು
ಬ್ರೆಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ ಏನೋ ಆಗಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಎಲ್ಲ ಕೊಡಿಸಿ ಲೈಕ್ ಇದು ಮಾಡಿತ್ತು.
ಫಾರ್ ಬ್ರೆಸ್ಟ್ ಕ್ಯಾನ್ಸರ್?
ಬ್ರೆಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ ಥರ ಆಗಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಎಲ್ಲ ಲಾಸ್ಟ್ ವರ್ಷದಲ್ಲಿ ಮಾಡಿ ಕ್ಲಿಯರ್ ಮಾಡಿಸಿದ್ವಿ. ಬಟ್ ಆದರೂ ಈಗ ಮುಂದೆ ಏನಾದರೂ ತೊಂದರೆ ಆಗ್ಬೋದಾ ಅಥವಾ ಈಗಲೂ ಚೆಕಪ್ಗೆ ಏನಾದರೂ ಕರ್ಕೊಂಡು ಹೋಗ್ಬೇಕಾ ಏನು ಅಂತ?
ಖಂಡಿತ ಅವರು ಫಾಲೋಅಪ್ ಹೋಗಲೇಬೇಕು. ಅವರು ದೇ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಫಾಲೋಅಪ್ ಬಿಕಾಸ್ ಫಾಲೋಅಪ್ ಹ್ಯಾಪನ್ಸ್ ಟಿಲ್ 10 years ಇನ್ ಬ್ರೆಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ಸ್. 10 ವರ್ಷಕ್ಕೆ ಅವರು ಫಾಲೋಅಪ್ ಮಾಡಬೇಕು. ಆ್ಯಂಡ್ ಫಸ್ಟ್ ಅದು ಹೇಳ್ತೀನಿ, ಫಸ್ಟ್ 2 years ಬಂದು ಫಾಲೋಅಪ್ ಆಲ್ವೇಸ್ ರಿಗರಸ್ ಆಗಿರುತ್ತೆ, ಒನ್ಸ್ ಇನ್ 4 months till 2 years, and after 2 years it becomes say once in 6 months. After 5 years it becomes once every year till 10 years of follow-up. And during this time I think each one will get patients will get definitive tests. ಏನೇನು ಟೆಸ್ಟ್ ಮಾಡಬೇಕಂತ ಡಾಕ್ಟರ್ ಹೇಳ್ತಾರೆ ನಿಮಗೆ, ಬೇಸ್ಡ್ ಆನ್ ಏ ಸ್ಟೇಜ್ ಹತ್ರ ಡಿಟೆಕ್ಟ್ ಆಗಿದೆ, ಏನು ಟ್ರೀಟ್ಮೆಂಟ್ಸ್ ಮಾಡಿದ್ದಾರೆ. ಒಂದು ಸ್ಟೇಜ್ ಮೇಲೆ ಡಿಪೆಂಡ್ ಆಗುತ್ತೆ, ಏನು ಸ್ಟೇಜ್ ಹತ್ರ ಅವ್ರಿಗೆ ಡಯಾಗ್ನೋಸ್ ಆಗಿದ್ದೆ. ಸಪೋಸ್ ಸ್ಟೇಜ್ 3 ಸ್ಟೇಜ್ 4 ಅಂದ್ರೆ ವಾಪಸ್ ಬರೋಕ್ಕೆ ಚಾನ್ಸ್ ಜಾಸ್ತಿ ಇದೆ. ಸೆಕೆಂಡ್ ಸ್ಟೇಜ್ ಆ ಥರ ಅಂದರೆ ಒಂದು 15 to 20% ಚಾನ್ಸಸ್ ಆಲ್ವೇಸ್ ಇರುತ್ತೆ ಫಾರ್ ದ ಡಿಸೀಸ್ ಟು ಕಮ್ ಬ್ಯಾಕ್. ಚಾನ್ಸಸ್ ಝೀರೋ ಯಾವಾಗೂ ಇಲ್ಲ. ಡೆಫಿನೆಟ್ಲಿ ಅರ್ಲಿ ಸೆಕೆಂಡ್ ಸ್ಟೇಜ್ ಅಂದರೆ ಇಟ್ ಈಸ್ ನಾಟ್ ವೆರಿ ಹೈ, ಬಟ್ ವಿ ಕಾಂಟ್ ಟೆಲ್ ಅಲ್ವಾ, ಯಾರಿಗೆ ಬರುತ್ತೆ ಯಾರಿಗೂ ಬರಲ್ಲ ಅಂದ್ರೆ ಹೇಳೋಕ್ಕಾಗಲ್ಲ. ಸೊ ಅವ್ರು ಟೆಸ್ಟ್ ಮಾಡಿಸ್ಕೊಳೇಬೇಕು. ಅವರು ಏನೇನು ಟೆಸ್ಟ್ ಹೇಳ್ತಾರೋ ಡಾಕ್ಟರ್ ಅದು ಮಾಡಿಸ್ಕೋಬೇಕು ಅವರು. ಎಸ್, ಡೆಫಿನೆಟ್ಲಿ. ಒನ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್ ಬಂದು, ಆಫ್ಟರ್ ಸಮ್ ಟೈಮ್ ಕ್ಯಾನ್ಸರ್ ರಿಲೇಟೆಡ್ ಟೆಸ್ಟ್ ವಿಲ್ ನಾಟ್ ಬಿ ವೆರಿ ಕಾಮನ್, ಬಟ್ ಕ್ವಾಲಿಟಿ ಆಫ್ ಲೈಫ್ ರಿಲೇಟೆಡ್ ಟೆಸ್ಟ್ ವಿಲ್ ಬಿ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್, ಅವ್ರು ಏದನ್ನ ಹಾರ್ಮೋನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ತೊಗೊಳ್ತಾ ಇದ್ದಾರೆ ಅಂದ್ರೆ ಬೋನ್ಸ್ ಹ್ಯಾವ್ ಟು ಬಿ ಚೆಕ್ಡ್ ಫಾರ್ ದೇರ್ ಡೆನ್ಸಿಟಿ, ಲೈಕ್ ಬೋನ್ಸ್ ಆರ್ ಬಿಕಮಿಂಗ್ ಬ್ರಿಟಲ್ ನಾಟ್, ಇದು ಖಂಡಿತ ನೋಡ್ತಾರೆ. ಆಮೇಲೆ ಹಾರ್ಟ್ ಚೆನ್ನಾಗಿದೆಯಾ ಇಲ್ವಾ ಅಂದ್ರೆ ನೋಡಬೇಕು. ಸೊ ಕ್ವಾಲಿಟಿ ಆಫ್ ಲೈಫ್ ಅಸೆಸ್ಮೆಂಟ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್, ನಾಟ್ ಓನ್ಲಿ ಜಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ ರಿಲೇಟೆಡ್ ಥಿಂಗ್ಸ್. ಏನು ಐ ಕುಂಟ್ ಹಿಯರ್ ದಟ್.
ಮತ್ತೆ ಹೇಳಿ, ನಿಮ್ಮ ಪ್ರಶ್ನೆ ಮತ್ತೆ ಹೇಳಿ.
ಅಂದ್ರೆ ಬ್ರೆಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ ಇದ್ರಲ್ಲ ನಾವು ಮಾಡ್ಸಿರ್ತೀವಲ್ಲ, ಲೈಕ್ ಐ ಮೀನ್ ಅವ್ರು ಸೇವಿಸ್ತಾರಲ್ಲ ಆಹಾರ, ಆ ತರದ್ರಲ್ಲಿ ಏನಾದ್ರೂ ಲೈಕ್
ಓಕೆ, ಊಟಕ್ಕೆ ಮತ್ತೆ ಕಾಯಿಲೆ ವಾಪಸ್ ಬರೋದಕ್ಕೆ ಸಂಬಂಧ ಇದೆಯಾ ಅಂತ ಕೇಳ್ತಿದ್ದೀರಾ? ಓಕೆ,
ಇಲ್ಲಮ್ಮ, ಆ ಥರ ಏನೂ ಇಲ್ಲ. ಡೆಫಿನೆಟ್ಲಿ ಮ್ಯಾಮ್. ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು.
So, coming back to our discussion, we know that information is power, but a lot of information can be overguiding or misleading. And in this era, many seek the help of artificial intelligence or ChatGPT. What's your comment on this, sir?
Um, Definitely, it is of help, but it can also be misguiding. Okay, so it depends on what you are feeding into AI as a question. It also responds to what one is asking, and then it will respond accordingly. Okay, but broadly, it would give people who can understand what is being told. AI can be really helpful. I am okay with that. But actually, sometimes it would drive a patient to question every decision taken by an oncologist in real time situation. Okay, AI can only tell you about things. It is not going to make critical on field decisions for you. So it will leave that to the oncologist who is seeing a patient. So I don't think we should entirely rely on AI to tell us what to do. But for a overall understanding, a basic knowledge, AI really helps. It does help in for people of literacy that yes, you are standing here, you have this condition, the likely way forward is like this. So they can always cross verify that with their oncologist. But if critically questioning an oncologist's decision, still I don't think they are in that state. I would
Yes.
disagree on that count.
Okay. So I think it's almost time, Doctor. Thank you so much for all the valuable information you provided, and you cleared a lot of myths surrounding cancer. To all our viewers, if you have any unusual symptoms, do not delay. And also, the session today reminded us that prevention, awareness, early diagnosis has the potential to save lives. Stay informed, stay healthy, and we'll see you in the next episode of Ask the Expert. Thank you so much.
I would like to wind up by saying
Sure,
that
sure. No. Yeah.
um, Vydehi Cancer Center is in its 25 years of existence. Okay, and we run a lot of awareness programs this year, support programs for patients. Okay, and then it's a large oncology center which focuses on patients purely for their better outcomes. So I would also inform the public that they are most welcome for any doubts in this regard. Thank you.